phenomenon, and we're talking about the freeze response. Now it gets a little complicated because you can have somebody who's in a freeze response who's experiencing overwhelming fear, anxiety, and has a high pulse rate. So it's an immobilized fear response. But there's also the calm, shut down, lower heartbeat, parasympathetic freeze response, which is what I'm talking about. So people with PTSD they have PTSD, so they don't just calmly stay in the middle all the time, just like people with manic depressive disorder don't calmly stay in the middle all the time, because if they did, they wouldn't have the disorder. So people with PTSD go up into the up pole, they get triggered by something, and they get all these startle, fear, scanning, looking, danger responses, and then they go down into the numbed out shutdown pole, and they try and stay there, but they get triggered back up. And then just by time, by mental effort, drugs, alcohol, acting out, something or other, back into the numbing phase. So it's bipolar. You're fluctuating up and down. And the typical scenario is the guy who was in Vietnam decades ago. He's in his backyard barbecuing. Everything's fine, no symptoms, no PTSD. A news helicopter flies overhead. Boom. Huge flashback, sounds, sights, smells, fear, terror. He's hallucinating a combat scene, he dives under the hedge. So that's the trigger, and the flashback is the intrusion symptoms. All that stuff was buried in the underground compartment, and boom, up it comes. And nobody debates that that's what PTSD consists of. So if we look at guys coming back from Afghanistan, there's kind of three subgroups. The middle subgroup is the one that I think, first of all, I question whether it actually exists really in reality. That's people who really have tons of combat exposure, but have no PTSD at all. Okay, so there's guys who don't meet criteria for PTSD, because there's kind of a cutoff. You have to have a bunch of symptoms, it has to be this severe. Whether there's any guys who come back from really horrific combat who have no symptoms whatsoever and are perfectly fine, kind of incomprehensible to me. But anyway, there's some guys who just don't have PTSD for whatever reason. And there's actually some studies in the literature showing that for the same amount of combat exposure, special forces guys have a lower rate of PTSD than regular combat guys, because they've had all this training and they're selected for being more resilient. So it actually looks like you can train people to be more resistant to PTSD. There's people who have obvious PTSD. So they're all flashback, startle, nightmares, anxious. They're easy to spot. Those are the people who get diagnosed. And then I think there's people who have unipolar PTSD. They look like they don't have PTSD because they're numbed out and shut down all the time. But they're numbed out, shut down, disconnected from themselves, and you've got a very numbed out, disconnected, shut down loved one, and the families say over and over and over and over, the guy who went over did not return. The body returned, but the person didn't. So that's unipolar PTSD. So now, in the whole literature on PTSD and the diagnostic criteria, everybody agrees that flashbacks are a core symptom of PTSD. Nobody says, this is what PTSD is. Flashbacks are just kind of like this little incidental thing on the side. And in the DSM, these are called, in the actual criteria, these are called dissociative flashback episodes. So the official position of the DSM in the literature is that dissociation's right at the core of PTSD. There's a bunch of academic debates about all that. So what has this got to do with the dissociative structural model? From my perspective, you could not have PTSD. Whether you call it an anxiety disorder or you call it, in the DSM-5, it may be in a group of trauma and stress-related disorders. No matter what you call it, it couldn't exist without a dissociated structure in place. Why? Okay, so I kind of compare this to the theory of gravity. There's a theory of gravity that's Einstein and professors of physics and all this mathematics, which is totally incomprehensible. That's the theory of gravity. But I have a theory that there's something called gravity that makes things fall to the earth. I don't know how it works. I can't do any mathematics on it. But I have this theory that there's got to be something, and we don't know what it is exactly, but we call it gravity. So that's not a big theory, that's just a piece of common sense. Sort of the same thing with the dissociative structural model. There's big academic theory, books, debates. But I'm saying this is just kind of a piece of common sense. Without, and basic logic, without a dissociated structure in place, you could not have the symptoms of PTSD. Why? Because these symptoms have to be stored in some disconnected underground compartment. They have to be in another window. Because if the person had no PTSD, was not numbed out, everything was resolved, was integrated, they would feel it, know it, own it, have processed it, mastered it, discharged some of the energy. And when the news helicopter goes overhead, the guy would just go, huh, sort of like back in Nam, and carry on with his barbecue. In order to have this quality of a flashback, it has to flash back from somewhere else. If it's already with you, it can't flash back. So all these intrusion symptoms, whether it's the picture, the sound, the physiological arousal, the fear, they can't flash back unless they're stored somewhere else. And you can't store them somewhere else unless you've done the opposite half of the process, which is disconnect, numb them out. So that's the withdrawal half. So it's constantly intrusion, withdrawal, intrusion, withdrawal. And you have to have these two compartments that have to be disconnected from each other, or you just can't have the symptoms. You just have thoughts, memories, feelings that are part of you. So that's why I say that structurally, PTSD has to be a dissociative disorder and has to fit the dissociative structural model. But nevertheless, there's all kinds of debates in the literature about is PTSD sometimes dissociative, never dissociative, always dissociative, and people write articles and take positions. I say, I don't care if you classify it as this, 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 or this, or what name you put on it, it has to have fundamentally dissociative structure in place. Okay, now let's talk about obsessive compulsive disorder. What is obsessive compulsive disorder? Just making sure I'm on track time-wise here. It's called obsessive compulsive disorder because you have obsessions and compulsions. The obsessions are the thoughts, the compulsions are the behaviors, basically. And to have obsessive compulsive disorder, there's two kind of criteria that have to be in place. There's a frequency criterion. That is, you can't have, there's all different forms of obsessive compulsive disorder. Some people count things or check things, check the locks, do repetitive behaviors. Some people wash their hands like literally 100 times a day and use all kinds of caustic soda, and hands are all red. So you can't have obsessive compulsive disorder because you do something every once in a while. You have to do it a bunch for it to be a disorder. And it has to be ego alien, that's a term in the literature, meaning that it doesn't come from you. It's ego alien. It comes from outside your ego yourself. It's something that you don't want, that you fight against. So typical obsessive compulsive person, if it's hand washing, this compulsion to wash your hands, you kind of push it down, it comes back up, you push it down, it comes back up, you push it down. And then finally, the anxiety builds up so high, you do the behavior, and poof, you get temporary relief from the anxiety. So, when I was back, let's see, this was last millennium, it was after the Dark Ages though, yeah. So it's back then. I heard about obsessive compulsive disorder and read about it and had some seminars on it. And just like real briefly, there was a mention of magical thinking in obsessive compulsive disorder. But just like a real quick mention, nobody focused on it. If you go to an obsessive compulsive conference today, or a journal or a book, nobody's going to be talking about magical thinking. There's not theories or models, and nobody bothers with it. But I always said to myself, magical thinking, what's that got to do with anything? So hold that thought for a second. In the obsessive compulsive disorder field, well, before I get to that, I'm just going to take a quick opinion survey here. How many people were thinking to themselves, I wonder if a couple of kangaroos are going to run through the hall here in the next 2 minutes? Oh, Better see me at the break. The rest of you. So that question just wasn't in our minds. We didn't have theories about it. We weren't thinking about the literature on it. It just didn't exist as a question. It's the same in the OCD field. Where did the obsessions and compulsions come from? If you go to a current mainstream conference, it's going to be all biological psychiatry stuff and some cognitive behavioral stuff. Nobody's going to be saying, here's my model as to where the obsessions and compulsions come from in a psychological sense. So they're like, well, obviously they come from inside your mind somewhere, and we might have some kind of brain model for that, but we don't really talk about that very much. Well, I say they come from the wounded inner child. So think about it for a second. It's not worlds of adult, analytical, rational, objective thinking. That's scared, magical child thinking. So when you go through all the symptoms of OCD, they're all unrealistic, irrational, but they're magical child thoughts. This is the way a scared, overwhelmed, magical thinking child might look at the world. So I say in OCD, you cannot have the symptoms, you cannot have the diagnosis without a dissociated structure in place. Because, I'm just going to exhibit my OCD here for a second. There we go, there's that water sipping compulsion again. Okay, so why do I not in fact have a water sipping form of OCD, which some people have? And you can actually, it's usually not pure OCD, but there's some people who actually drink so much water, so compulsively, that they throw their electrolytes out of balance and have a seizure or die. So it can actually be life-threatening. The reason I don't have a water-sipping compulsion is I don't do it unusually often. And I don't have this internal experience of drink, 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 drink. No, 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 I'm busy giving a lecture. Drink, drink, drink. No, I'm busy giving a lecture. And my anxiety builds up, and then I have a sip, and I go, it just doesn't operate like that. So I just, in this, at least this part of my life, I have a relatively integrated, healthy, fluid, flexible self, and I just go, I'm talking, my mouth's a little dry, I think I'll have a sip. To be obsessive, an obsession or compulsion, it has to have that quality of intrusion. It has to be ego alien, it has to come from somewhere else, it has to push in, you push it back down, it pushes back in, you push it back down. So it's another form of bipolar intrusion withdrawal. And if there wasn't a dissociated structure, you would already own the thought or the feeling or the impulse. It would originate inside you, it wouldn't intrude, and you wouldn't have the disorder. So again, OCD is just another variation on the theme of a dissociated structure with intrusions and withdrawals. And couldn't be. Sorry?
ANP, what was that?
Apparently normal personality. That's the adult self. EP is the emotional personality, which is the wounded child. And that's just the vocabulary that these guys use in this way of talking about it. So in the literature, as I mentioned, psychiatry is pretty dominated by this biological brain way of looking at things now. And there's always the psychological. And then we have social and spiritual and cultural kind of minor things thrown in there. If you go to the biological psychiatry conference on OCD, nobody's talking about magical child, nobody's really talking about trauma, nobody's talking about the dissociative structural model. They're talking about brains, genes, chemicals. But when you look at the model, it's a dissociated structural model in brain language. It's all about this brain system and this brain system are not communicating and talking to each other, and there's sudden unregulated intrusions from some part of the limbic system to some part of the cortex or whatever are the details. So even though the words dissociation, the subject of trauma, magical child, wounded child, none of that exists, it's still a dissociated structural model of brain subsystems, because it has to be, because otherwise you couldn't have the disorder. So inherent in all the biological models of OCD is a dissociated structural model, just not called that. And same with all the psychological models. Then we get to treatment. And so the world is so complex, so we have to boil it down to simple models. So here comes a simple model. You can summarize mainstream treatment these days that dominates the literature is mostly medication and cognitive behavioral treatments. If you go in the medication literature for any disorder in psychiatry, there's nobody who's claiming that any psych med cures anything. It's universally, there's not one person stands up at a conference and goes, hey, I think we're curing things. So all these medications do is they suppress symptoms. They put a lid on things. And if you stop the medication, the reason that psychopharmacologists, they don't go, take these meds for 3 days and then you'll be fine. The family doctor goes, take this antibiotic for 7 days and you'll be fine. You can stop it. If it actually works, which it does a lot of the time, then you actually are fine. You don't suddenly relapse. But if you have OCD and it's been chronic and severe for years and you start the meds and you take them for a month and you stop, of course, you're likely to relapse. That's what all psychopharmacologists say about OCD or schizophrenia or depression. For depression, maybe if you take a year or two, sometimes you can stop and be depression-free for a while, but you may relapse down the road. So nobody debates this point. That all the meds do is put a lid on things. If you take the lid off, stop the meds, the symptoms come back. And there may be some withdrawal thrown in there. If we look at the cognitive behavioral literature, the sort of mainstream hardcore cognitive behavioral literature for OCD, and we look at the vocabulary is things like response, prevention, cognitive distancing. It's all a vocabulary of pushing it away, not responding, ignoring it, not buying into it, focusing on something else, which is, again, putting a lid on things. So these cognitive behavioral and medication are basically suppression models. And if you successfully suppress that wounded magical inner child, and you don't hear from that child, then you have a treatment responder, you have no symptoms, life is great. Until you take the lid off, and then back come the intrusions because the wounded child has not been cured. Now, remember, this is a structural, not an etiological model. So in theory, you could have a dissociated brain structure with these intrusions of this magical thinking from your limbic system or wherever, based on a genetic defect, brain injury, some kind of infection. There could be dozens of different causes. It doesn't have to be trauma, but often it is.
Can I ask a question?
Anybody in this room can ask questions except for you because you're a radical. But I'll give you one try.
When you're talking about more of the, like depression, where there's always a difference between major and versus like brain and injury and those kind of causing infections, but what if it's just trauma? Is it possible for that to, once it's been worked through, that you wouldn't necessarily have a relapse, or do you still feel that that's more?
So here's the whole $64,000 question. Well, she's saying if the cause is trauma, can you work through it and then not have a relapse later on? A little bit, it doesn't matter what the cause is. In theory, if you have a suppression-based treatment, no matter what it is, and no matter whether it recognizes the trauma or doesn't recognize the trauma, if it's suppression-based, you basically can't have healing and cure. The only way there's a possibility of healing and cure is an integration-based treatment method, where you're not squashing that wounded inner child down, you're listening, accepting, soothing, healing, owning, curing. Then, when there's no longer dissociated structure in place, because the child has been integrated with you, you've discharged some of the energy, you've gathered a bunch of new tools in your toolbox and life skills and so on, then you can't have an intrusion because it's already with you. So the possibility, now we have to go to the outcome literature and see, well, does it actually work or not? But there's no possibility of recovery from a suppression-based model. Now we're going to jump to another section of the DSM called the impulse control disorders. And so if you want to learn about impulse control disorders, you'd have to go to an impulse control expert, conference, journal, books, because that's a whole different thing from anxiety disorders, one of which is obsessive compulsive disorder. And one of the impulse control disorders is trichotillomania, which is where you pull hair out of your head. So this illustrates how arbitrary the whole system tends to be. Any obsessive compulsive behavior that you do over and over and over, picking at your skin, sipping, drinking, counting, checking, that's an obsession, and that's a form of obsessive compulsive disorder, which is in the anxiety disorders, unless what you do is pluck your hair. Then that's not a compulsion, that's an impulse, and it's an impulse control disorder. And this is taken very seriously, and there's turf wars about it, and theoretical arguments. Finally, it looks like in DSM-5, which should be out in 2013, probably trichotillomania is going to be moved over to the OCD section. So finally, that makes sense. But there's many, many, many things in the manual like this that are very, very arbitrary and just based on history, turf war, politics. But it doesn't matter that much because the main intermittent explosive disorder, main impulse control disorder is intermittent explosive disorder. So again, so stereotypically this is the guy who flies into a rage and beats up his wife. Nothing to do with OCD, nothing to do with PTSD. It's over here in this separate section of the manual. So in the DSM-3, in the text described, there's in all the areas of the DSM, there's the actual diagnostic criteria, which are kind of in a little box. Those are the actual rules for making the diagnosis. And then there's a whole bunch of text that discusses all kinds of stuff about the disorder. So in the text in DSM-3, which came out in 1980, for intermittent explosive disorder, it said there's frequently amnesia for the period of explosive violent behavior. And there's a whole literature supporting that, but that got kind of dropped out in DSM-4 for some reason. And again, just really simplifying things, you could say there's a biological model of intermittent explosive disorder and a psychological model, which there actually is in the literature. So, I mean, I actually know people who have teenagers who have intermittent explosive violent behavior, and they take EEGs on them and try and find little abnormalities in a certain part of the brain, and then they give them seizure meds in the hope that this is going to drop the behavior down, because it's a seizure-like behavior. So the model here is your brain just has this electrical storm, and it causes you to not fall down and shake, it causes you to punch your wife. The other model is, these models actually in reality, of course, are all blended together, and it's not two separate compartments. You would think in theory, but actually in the field, the biological compartment often functions as a kind of a caricature of itself, and there's no psychology around anywhere. And then the psychology compartment ignores the biology compartment in actual practice a lot in the field. So we've got these two models. One model says this is just some kind of electrical explosion in the guy's brain causes him the seizure, but it's not a typical falling down and thrashing around seizure, it's a punching your wife seizure. And then afterwards, of course, the guy doesn't remember because you don't remember when you're having a seizure. And then the other model is this guy's got an anger management problem. And it isn't just a brainstorm that comes out of nowhere. Let's take a look at, oh yeah, so his dad beat him, his dad beat his mom, he was socialized and programmed to be somebody who's a male chauvinist pig who's got no respect for women even though he's married to one. So it's a whole social psychological model. And we don't have a guy who's walking around fine and all of a sudden blows up. We've got a guy who's sitting on a volcano of anger. Now, if this was actually a seizure model that was operating in reality, people who actually have epilepsy, you can trigger seizure sometimes with certain things, but by and large they happen kind of at random. If beating up your wife was actually a seizure problem, then occasionally guys would beat up their wives in front of the police department or at the checkout line at the supermarket. For some peculiar reason, this doesn't seem to happen. So it's not randomly distributed in time. There's actually a setting and a context where it's more likely the wife's going to get beat up. So one example would be, guy comes home from work, walks in the house, and there's the wife. A little bit of drool going down. And there's Brad Pitt on the TV. That might warrant getting beat up. Or you're at the party, wife's had a couple of drinks, she's starting to flirt with this other guy. Time to beat her up when you get home. So there's a trigger. There's something that sets this behavior off. What is the trigger? The trigger is real or perceived threatened abandonment by your primary female attachment figure. What is the trauma? Guys don't, guys who go into combat sometimes come home and murder their wives. But they don't do that simply because they've been in combat. The combat is poured on top of a whole bunch of pre-existing problems. What is so the trigger is the wife is threatening to abandon you, either just emotionally or actually divorce you. What is the prior trauma? So the guy doesn't beat up his wife when the news helicopter flies overhead, because that's the trigger for combat in Vietnam, and up comes a combat scene from Vietnam. The guy beats his wife when she threatens to abandon him. What's the prior trauma? Real or perceived threatened abandonment by your primary female attachment figure named mom. So the prior trauma is completely different. It's a failure of bonding, nurturing, attachment, unconditional love. Then here you are as an adult male, you want back to the nice guy husband who's the coach of the baseball team, who's did this and this, and he gives you a huge box of chocolate, a whole bunch of candies, apologizes, says he'll never do it again, and everything is great because we've numbed out and shut down that wounded child. Then when the wounded child is triggered again, up comes the abandonment fear. Then we harness the rage, we solve the problem. So, I'll take a question in a second. So what I'm saying is intermittent explosive disorder is exactly the same thing as PTSD. The same dissociative structure, and all that's different is the original type of trauma is different, and what comes intruding up is different, but not so different. Because what is it that's so scary about combat? You might die. So intermittent explosive disorder and PTSD should actually be beside each other in the same section in the manual because they're both trauma threat response systems. The different type of trauma and a different component that intrudes up.
So using your example, what? So he comes home, dinner's not on the table, he beats her up. So where's the trauma, the wounded child, the whole, I'm being abandonment, his first reason for...
Okay, so that's a very good question. The guy comes home, dinner's not on the table. We've heard this story 27,000 times at the battered spouse shelter. What's the problem with dinner not being on the table? Dinner not being on the table, it's just not a survival threat in objective reality, right? It's not that big a deal. Okay, so I have to wait half an hour for dinner. It's exactly the same as the news helicopter going overhead. The news helicopter is just flying overhead. There's no threat. There's nothing wrong in the present. There's nothing. So PTSD is always an overreaction. When it's a female, we call that being hysterical or borderline.
Yeah.
Because, women are that way. When a Navy SEAL does it, we call it PTSD, and we're related to combat. So the whole point is that the threat in the present is tiny in objective reality. It's a trigger. So the logic sequence is, dinner isn't on the table. That proves I'm not important. That proves I don't care. That proves I'm not getting enough respect. That proves that she's the one who doesn't care. If she doesn't care, she's probably going to leave me. If she leaves me, I'm going to feel this way. That's a giant crisis, kapow. That's how it operates. Does that answer your question?
So therefore, because most of what happens now is in Central 52, the anger management. So rather than looking at as managing the anger, it sounds like what you're saying would be more effective is looking at it as a dissociative disorder and handling more as a PTSD.
Right, because what does spousal battery 52-week anger management consist of? Mostly it's a suppression-based model. And they're not coddling no little scared boys inside no spousal batteries. So therefore, I say it doesn't work. Now, practically speaking, of course, if you actually offered a recovery-based, integration-based, trauma-based model of therapy to 1,000 guys who beat their wives, how many would do it for real? 2, 7, I mean, not an overwhelming number. So then you try as good a suppression-based model as you can and hope for the best, and it doesn't work all that well. That's called reality.
Question.
Yep.
I know that amnesia about these, explosive episodes is no longer in there, but working.
It's in
with-
reality, it's just not
I
in
know,
DSM.
and I know. And one of the common responses I get in working with perpetrators is this, but I don't remember. And I'm having to work with the suppression model in terms of offering court-mandated classes, but we are always going back to, I have very small groups, and it is very, I think, probably counter. I think if I had someone in observing the classes, they would decertify my class, because we do look at.
Is everybody able to hear what she's saying? She's doing small classes with batterers, and she's just saying it's a court-mandated suppression-based model, and if somebody came in and observed their classes, they might fire her.
Yeah. This amnesia about it is very difficult for me to handle. I just typically accept it and say, could be. But let's look back at the police report, because other people are telling us what went on. May not be 100% accurate, but someone was alarmed enough to call authorities. And so I can't always, I try not to coddle too much, but I want to acknowledge that they may actually not remember. They describe a lot of just blanking out, I don't remember until later.
Right. I agree that the amnesia for the, just clinically on my experience, which is relatively limited because I mostly work with mostly females, mostly victims, but because guys are just too much to deal with, basically. So this amnesia is a very recurrent, common theme. So if I was working with somebody, I'd go, okay, so first of all, there's always, I'm talking to the guy now, there's always the possibility that you're just running a con here and you're just pretending you don't remember because you think if you don't remember, then somehow you're going to get off. But actually, I have no doubt that many spousal batterers genuinely don't remember quite a lot of the time. So let's just go with you genuinely don't remember. Okay, so that explains why your wife in fact didn't have any bruises on her face. Well, so what if you don't remember? That's something we can work on, we can try and understand. But whether you remember or not has no relevance at all on the impact of your behavior on your wife and your children. So how about if we look at the impact on your wife and children? Now, people often have amnesia for doing things to